Шановні колеги, шановні друзі,
Dear colleagues, dear friends, we are happy to welcome you at our 13th webinar on track to improve health of women living with HIV Ukraine. And we organize it with the support of European AIDS Clinical Society, EX, as part of WAVE group activities, which is a working group of EX, and this group is working, focusing its attention on women and their health, and they support us in having our webinars, and this is the 13th of them. I just want to remind you that it's a bilingual broadcasting, Ukrainian and English, and in case some of your colleagues cannot join now, and hear us and watch us. So for 2 weeks, this video is going to be on the EX website. It's going to be recorded so they can watch this recording. Also, I would like to tell you that you, our participants, are very important to our webinars, and your questions make our webinar more interesting, more relevant. So please send all your questions to our chat. We will be looking at them. We will do everything possible to answer those questions. Okay, so for the start, I would like to introduce our chairs with us today. Ms. Nina Weiss, professor, PhD, medical doctor, Hvidovre Hospital at University of Copenhagen, Denmark, Faculty on Health and Medical Sciences, Department of Clinical Medicine, University of Copenhagen, Denmark. And Nina also is vice chair of WAVE. And also another co-chair is Caroline Abbey-Popp, and this is our friend, and she's been our friend and is our friend for many years. Doctor, consultant, obstetrician, gynecologist, researcher, Department of Infectious Diseases, University Hospital, Bern, Switzerland. And our third co-chair for today is infectious diseases doctor, honored doctor of Ukraine, researcher at HIV/AIDS and viral hepatitis department at the Institute of Epidemiology and Infectious Diseases, named after Gromashevsky, at National Academy of Medical Sciences, Ms. Svetlana Antoniak from the city of Kiev, Ukraine. All right, so let's hear the welcome words from our chairs. Caroline?
It's my great pleasure. Thank you, Sergey, for this introduction. To welcome you also to today's workshop, the 13th we built in WAVE. We gather here not only health professionals, but also policymakers, advocates, and community members to drive a meaningful change in the response to HIV. And this workshop actually was built to find new collaborations and to find better understanding for women living with HIV. I think now in October 2025, we are at critical crossroads in the response to HIV, because on the one hand, we have better tools than ever to prevent and treat HIV. We will discuss treatment today. But on the other hand, we face these inequalities and persistent gaps in access to care across the regions. And this, of course, is one aim of our workshop, to create dialogue, to share the latest data and to share good clinical practice, difficult cases, and also to work across disciplines and across borders. And I know in this humanitarian crisis times, it's even more difficult. And I admire your resilience, and I admire your persistent collaboration and attendance of this workshop. And I think your today's attendance is also a testament for your commitment. And I thank you for that. And I wish you a very good workshop that inspires you to continue with our work and that builds a stronger collaboration and stronger friendship. Thank you.
Дякую, дуже дякую, Caroline, за такі теплі
Thank you so much, Caroline, for such warm words. And I'm giving the floor to Ms. Nina. You're most welcome.
Thank you, and good afternoon, everybody. It's a great pleasure and privilege to be with you here today for this webinar. I've had the pleasure before, and I've been looking very much forward to spend this afternoon together with all you brave people. I've been looking forward to discuss with so many dedicated professionals and maybe also community members committed to advancing the health, rights and well-being of women living with HIV. I can only say that I agree very much with Caroline. It is in many, many different ways a very difficult time. We have the possibility to treat everybody with HIV with very good and effective medicine. We have the possibility to prevent transmission from mother to child. And even though, as we speak, October 2025, I think things are really changing many places in the world, and we must all do our very best to prevent that the things turn in the wrong direction. So welcome, and thank you for letting me be here. Thank you.
Дякую, дякую, Ніно.
Thank you. Thank you so much, dear Nina. So, dear Svetlana, you're most welcome. Dear colleagues, I'm very pleased to welcome you to the 13th WAVE EX webinar on track to improve the health of women living with HIV Ukraine. And I would like to sincerely thank you for your interest. And despite all the challenges of today and your busy schedules, you still find time to participate, to discuss important issues related to antiretroviral therapy, new treatment strategies, with a special focus on the needs of women. And traditionally, I would like to say my warmest gratitude to Dr. Caroline Abbey-Popp, a medical doctor, Master of Sciences, who works as a consultant obstetrician, gynecologist, and researcher at Department of Infectious Diseases, University Hospital, Bern, Switzerland, and who is a co-chair today, and she always participates in our webinars. And it was actually Caroline Abbey-Popp, together with Professor of Warsaw Medical University, Justyna Kowalska, and Professor Fiona Kahi, who worked at St. James Hospital in Dublin, inspired us to hold WAVE EX webinars on track to improve the health of women living with HIV Ukraine. So now we are gathering for the 13th time online. It's like a breath of fresh air in our routine difficult times. And let me express my hope that we will meet again live in Kiev and again visit the beautiful Taras Shevchenko Opera and Ballet Theatre and enjoy art. Also, I would like to thank Professor Nina Weiss, Doctor of Medicine, Hvidovre Hospital at the University of Copenhagen, Denmark, who is also co-chairing and participating in today's webinar discussion. And we know there was a huge input in the area of HIV you have made, dear colleagues. And we are very grateful to the speakers and participants in the discussion from Europe for continuing to help Ukraine. And it's a great honor for us to hear from world-renowned HIV therapy expert, Queen Mary University of London Professor Dr. Chloe Orkin, and to discuss the topic of the latest HIV therapy in women. We know that Dr. Chloe Orkin was the principal investigator of the first ever phase 3 clinical trial of injectable antiretroviral drugs. We observed the results of studies such as ATLAS and FLAIR on long-acting intramuscular cabotegravir and rilpivirine injection therapy. And We support undetectable is untransmittable strategy. Equals you. We support the idea of inclusiveness in overcoming inequality in healthcare and medicine. Many thanks to Maria Lulchuk, MD, head of the Laboratory of Molecular Virology and Deputy Director of the Gromashevsky Institute of Epidemiology and Infectious Diseases of the National Academy of Medical Sciences, a key expert on antiretroviral resistance in Ukraine. And she will share her experience in monitoring resistance and clinical cases of acquired HIV resistance in women. And we are very grateful to Olga Klimova, an infectious disease specialist at the Public Health Center, who will participate in the discussion. The interest of Ukrainian doctors in WAVE webinars focusing on important health issues for women living with HIV remains high. And we are very grateful that regardless of the war and the sleepless nights, we continue to work in our webinar, and we understand that it's very important to consider to continue to provide assistance today. And this is the fact that we do that shows the sustainability. And today we are focusing on important issues related to ART, the latest HIV therapies, with a focus on the needs of women. And today's moderator is Serhiy Antoniak, research associate at the Department of Viral Hepatitis and HIV at the Lev Hromashevsky Institute of Epidemiology and Infectious Diseases, and also a member of the WAVE committee. Thank you, dear Svetlana. Thank you, dear colleagues. Truly, those are really important topics that we would like to discuss today. And the overarching topic of today is new strategies of ART and women. And briefly, we will remind you about our agenda, our program. And just a reminder that after today's webinar, you will have to undergo testing for you to assess the quality of our webinars. It's not to assess your knowledge, no way, it's just the quality, how we provide information to you. And after that survey, after that questionnaire, you will be able to get your certificate of participation, and you will be able to get your certificate after that. So according to our agenda, so today we will start from a mini lecture, Novel Therapy for HIV and Women, presented by Chloe Orkin, a professor of inequities and infectious, dean for healthcare transformation, consultant physician at Barts Health NHS Trust, director Share Collaborative and Health Equity, Immune Biology Center, Blizzard University, and Queen Mary University of London, from Great Britain. So, Ms. Chloe, maybe a few words that you would like to say in the beginning.
Hi, everyone. It's a real pleasure to be here, and thanks for the invitation to this great meeting. As we've heard, my real focus is really around inequities and infections and access to care and engagement in care, and also around novel therapies. So I've tried to talk in this talk about some of the options that are available, some of the priorities, and also to give you some idea of what's coming in the future, well, what's at least coming to some of us and where the field is moving, to give sort of an understanding of that. And I hope that you'll enjoy the talk, and I share the feelings of my colleagues that absolute respect and admiration for all that you're doing in such incredibly difficult circumstances. And it's an honor to be here, and I hope the talk is helpful. Hi, I'm Professor Chloe Orkin. I'm Professor of Infection and Inequities in London. And I'm also a doctor looking after people living with HIV. And I'm going to talk about novel antiretroviral therapies and women. Here are my financial disclosures. So what we know about treatment is that treatment used to mean handfuls of tablets. And then we got to the point where we had single tablets, which was brilliant. And now what we've learned is that less is more, and we can treat people with pills that just contain 2 drugs, not 3. And we do this to try and improve quality of life for the long term. And we also now have an injectable treatment, which means 2 injections every 2 months in countries where this is available. And this contains a drug called cabotegravir and rilpivirine, which I'll talk about a little bit later. So why is it important to think about women and girls? Well, because they represent more than 50% of the global epidemic. And we can see that this is particularly the case in East and Southern Africa, but we also see a large representation in Eastern Europe and Central Asia. And gender does shape the risk and experiences of HIV in many ways. At an individual level as a woman, interpersonal level in terms of how people are treated as women, and then institutional levels in terms of how people are treated within hospitals, within their communities, the stigma they experience, and then things like public policy, which don't fund women's studies as much as they should. Like, for example, in the UK, studies about women's health conditions only get about less than 5% of the overall funding. So this is how public policy can affect things. So where are we now? Despite accounting for more than half of the global population living with HIV, women are grossly underrepresented in research. They may face, as a result, a number of health inequities and unmet needs, because if we don't study things, we can't know about them. And there are also specific considerations for women living with HIV, dealing with different life events. So we have to think about, for people planning families, contraception, and we also need to think for transgender women around affirming hormones, gender-affirming hormone therapy, and potential interactions. We need to think about the effects of drugs during pregnancy, safety, vertical transmission, feeding, and neonatal testing. And then we have to think about older age, barriers to adherence, comorbidities and polypharmacy, and also menopause, the fact that it can happen early, and what drug interactions there may be with menopause treatments, and also the fact that people living with HIV sometimes may have more menopause symptoms and also receive less hormonal treatment. So if we think about hormones, many women use reproductive hormones, contraceptives, menopausal hormones, and also gender-affirming hormone therapies. And there are some potentials for drug interactions, particularly with protease inhibitors and with some NNRTIs, older drugs. So selecting drugs in women may be based on potential DDIs, which may in fact also affect contraceptive options. So women should have access to contraceptive options that allow them to plan for and prevent pregnancy. And luckily, nowadays, because of integrase inhibitors, this is much less of a concern. So if we think about novel treatments, there is quite a lot of interest in new drugs. And there's a lot of interest in 4-monthly injections. There's interest in weekly tablets, monthly tablets. And before we had the first injectable treatment, there was quite a lot of interest in this. And this interest has continued since the drug has been developed. So we now have this 2-monthly injection called cabotegravir rilpivirine, 6 injections a year. And this year, it's actually come into the World Health Organization guidelines as a recommendation. So this is really important, because what this means is the World Health Organization are saying that this is something we should be striving to offer people across the world, this innovation. And what we know in studies so far of cabotegravir rilpivirine, what you can see on the right is the country proportion included in studies, and what you can see in the red is the number of studies where the proportion of women included is lower than the country proportion of women living with HIV in that country. So we're seeing that there's a lot of underrepresentation in the studies. And we're talking about the real world studies now of clinical practice using injectable cabotegravir rilpivirine. So this is the reason that I felt it was really important in the study that I led around cabotegravir piperine in the UK, to also make sure that we included a good proportion of women, also racially minoritized people, and older people. So our study was looking at delivering cabotegravir piperine in both the clinic and also in the community. But we set these targets for at least 50% women, 50% racially minoritized people, and 30% over the age of 50. We did the study in 6 sites, and each site was allowed to choose a community setting where they thought they could deliver the treatment in the second 6 months. So we managed to recruit 54% women, 70% who were racially minoritized, most people in the study were Black, and 40% were over the age of 50. So it is possible if you intend to do it. And what we found is in this population, which actually represented both men and women, there was very few people who experienced virological failure. Almost all of the injections were given on time, and there were some withdrawals from the study, but mainly the withdrawals were not related to the viremia. They were related to people moving or injection-related reasons or pregnancy. So I'm going to move on to showing you a slide around cabotegravir piperine, the injectable treatment, and use with gender-affirming hormone therapy. Because I think sometimes we forget that we need to think about androgens, sort of male hormones as well as female hormones. And what you can see here is that it's green. So green means no interaction expected. And in some cases with androgen blockers, there are some situations where you would need to consider this. So with high testosterone doses, it can increase the muscle growth and blood flow. And what this will do is it will release the cabotegravir piperine from the gluteal muscles, from the buttock muscles, increase the elimination, which could reduce exposure to cabotegravir piperine. So other than testosterone, we can see that in the main, you can prescribe gender-affirming hormones. So you can see that for the estrogens, there's no problem at all. For most of the androgen blockers, it's fine. But if you want to give testosterone itself, that can be an issue. So that's important to know. So I guess the other thing that I wanted to talk about in terms of what are options in general are what drugs are coming soon. So I think what I told you about was cabotegravir piperine, and I told you that there were significant quality of life improvements for people who are on these drugs, better treatment satisfaction. I told you, and I'm telling you also about preference, and most people prefer to continue on the injection, and that includes women. So what I want to talk to you about now is where we're going from here. What are the new therapies that are coming to us? So firstly, there are some daily combinations which are coming. The first of these is doravirine islatravir. And this is a 2-drug therapy. It's a daily therapy. And it doesn't contain an integrase inhibitor. So it means that for people that can't take integrase inhibitors, there is a single tablet option for them that doesn't contain this. So this is good news. And it's been shown to be as effective as bictegravir, FGC, and TAF, and as other therapies. And it was presented this year at CROI. Then there's a very important drug which is being developed. And this is a single tablet containing bictegravir, the integrase inhibitor, together with lenacapavir as a tablet. Okay, so the lenacapavir is the drug we've all heard about for PrEP, but it's also being developed for treatment. It already exists as an injection, but they're also making a single tablet with this drug, a tablet to take every day. And this is a very, very important combination for people who've been taking handfuls of drugs, for people who've been taking twice daily drugs, okay, for people that have been living with HIV a long time. And this population has been left behind. None of the treatments, the new treatment innovations that have been developed for people who have sort of on 2-drug therapies, on complicated therapies. So this is very important. This will be important for adolescents who can't take cabotegravir or pivarine. This will be important for, many people who are taking difficult regimens. Then there's weekly drugs. There's a couple of regimens being developed. There's islatravir with ULO, which is a new NNRTI. There's islatravir with lenacapavir being developed weekly. And these are very promising options. And a lot of people living with HIV are very interested in weekly therapy. There's another weekly therapy combination, which the study is on hold because it's affected CD4 count. So that is the bottom two. The WONDER study is on hold. So as with all clinical drug development, we can't guarantee every drug is going to come to market. Then there's a whole lot of other options in terms of injections. You can see on the left, potential 2-monthly injections, some 3-monthly injections being developed. And then there's a plan to develop cabotegravir or pivarine, which is the 2-monthly injection, into a 4-monthly injection. And we are hoping that studies are going to start in 2027, okay, so in a year's time, to see if we can get this treatment to only 3 injections a year. So that would be amazing if we could do that. You can see on the right, there are also infusions, okay? Now, this means it's not just an injection. It means you have to have a drip, with a bag, and it goes in over an hour or 2. So it's a much longer process. And all of these drugs are something called BNABs on the right. It's a type of synthetic, man-made or human-made antibody against the HIV virus. And these drugs are quite complicated. Not everyone can use them. Some people's type of virus are not susceptible to them. A person can develop resistance to them when they're on them. It's a whole new type of therapy, and it's very complicated, and it's also not easy to give because it can take a lot of time. So I think this is a bit of a science experiment, but we'll see where this goes in the future, but I'm telling you about it. So I think in summary, what I would say is that we have an existing 2-monthly injection, which is already showing that this type of new therapy is very important and very much wanted by people living with HIV. But 6 times a year is a lot. It's a lot for healthcare providers, and some people may not want such a frequent treatment, which is why it's really important that we continue to develop new therapies. But it's really important that these new therapies are used in women, and that women enter the studies, and that they're encouraged to do so, and that it's made possible for them to do so, because otherwise we don't know enough, and we won't know enough about these new therapies. The other thing about the future is that almost every single one of these regimens that I've shown you consists of 2 drugs, not 3. So we really are moving to a point in the future where 2 drugs, not 3, is the way we're moving forward with treatment. Also, very important to say that none of these combinations contain any treatment for hepatitis B. Right now, almost everyone who is taking 3-drug therapy now is on some sort of tenofovir or TAF. And tenofovir with 3TC or FTC plus TAF, or is a TAF or TDF, as some type of tenofovir with FTC or 3TC is also a treatment for hepatitis B. So most people nowadays are already taking something that will control hepatitis B if they have it. But in the future, this protection will not be there anymore. So it's very important that people are vaccinated against hepatitis B for the future, so that their regimens will not lead them to a situation where they might get a new episode of hepatitis B, or in people that have had hepatitis B, that it doesn't reactivate. So this is something as a field we're going to need to consider. Finally, it's very important that these drugs do not just stay in well-resourced settings. And this is a very sad and a difficult slide to be sharing these days when we understand what's happened in public health and the loss of the programs and the loss of funding for PrEP and for women's health, globally since the beginning of the year with the Trump government. This is a very sad and very awful situation, and many things are up in the air, and people you know, many countries are not able to get any treatment. Treatments have been interrupted, let alone new treatments. But that doesn't mean we mustn't fight for new treatments to be developed and for them to be available in the future. So we need to continue to motivate for new drugs, for women to be on these new drugs, and for these options to be available to all people everywhere. Thank you for your attention. So thank you for listening. And I've asked for this slide to be shown, which has also been shown in Ukrainian on the Ukrainian screen. So this is a study that I'm currently leading to try and understand why, although this injection is available and people are interested in it, less than 2% of people in Western Europe are on it. So what we know is that people like it when they're on it, but what we don't know is what discussions are taking place with people living with HIV. What is actually being discussed? And actually, we do know because we've done an analysis and we know not a lot is being discussed. So I think the study is open. It's recruiting until the end of the year. We are very equity focused. So we have translated the whole survey into Ukrainian, into Russian, into 18 different languages. You'll be seeing a Ukrainian advert. Unfortunately, the study is only for people in countries where cabotegravir or pivirine is available. So if you are Ukrainian, someone living with HIV, or you're looking after Ukrainian people and you're living in Western Europe and you have patients in Western Europe, or you know people in Western Europe who are living with HIV, the survey is for them. Okay, because we very much want to understand what is the perspective of women from Ukraine. What are they being offered? Where are the inequities? We really want to hear from these people, really, really, really. And the survey is completely anonymous. So that's that. And if you happen to be listening and you've joined this survey, joined the session, but you're not Ukrainian and you've joined to hear the data, then you're also welcome to participate. So thank you for listening, and hopefully you'll hear more about the study in due course.
Я хочу подякувати вам, пані Хлоя, професор Хлоя.
I would like to thank you, Professor Chloe Orkin, for this wonderful, fantastic presentation. And thank you for your views and perspectives. Thank you for saying that we have to try and strive for equality and equity. So far in Ukraine, we do not have access to cabotegravir and rilpivirine. And with us, Olga Klimova is with us. She works at Public Health Center Ukraine. Also, she would be saying something about that, but also I would like to say that we always try to get as quality treatment, as highest quality treatment as possible for our patients. And we have more than 100,000 people in Ukraine getting ART, and we have a unified regimen, but integrates inhibitor, TAF50C, TDF50C, and dolutegravir. So it's dolutegravir based, and we believe it's not bad. And cabotegravir, we have only for PrEP, but we have it for PrEP. And then maybe a bit later, Ms. Olga Klimova will mention something about access of women to cabotegravir. So once again, thank you once again. Thank you very much. Yes, thank you. And we will be trying to get this high standard, high quality treatment for our patients. So we will be dreaming of those novel technologies, because some time ago we didn't have any hope, you know, and no hope was even for usual highly active ART. But for 25 years, we already have it. So we have this access in Ukraine. So hopefully that in future, we will be achieving our new goals and achieving better quality of life for our patients. So once again, thank you. I can continue, dear Svetlana. Ms. Chloe, thank you really so much for this very interesting and useful presentation. So this information that you have outlined, you presented, is very valuable for our country as well, because as Svetlana has mentioned before, as of today, we are working on implementing injectable cabotegravir, but it's only for prophylaxis, for prevention. We are trying to do it as safe as possible. Here in Ukraine, this year, so 192 persons have got injectable cabotegravir for prevention. Only 15 out of those are women. And by age, those 15 women is 15 to 19, one, from 15, 19 years of age, from 20 to 24, only one as well, and 13 women from 25 to 49 years of age. So among those 15 women, one is transgender woman, and that is why we would like to ask you to share your vision with regards to the following. Which are the criteria of selecting patients for cabotegravir rilpivirine long-acting in your practice? So how do you select people for that? What are the typical or standard side effects for long-acting cabotegravir rilpivirine, especially in women in menopause or with comorbidities? And also, we would like to hear your vision as of today with regards to safety using cabotegravir in pregnant women as prevention, as HIV prevention, in particular in those who are already, for example, getting that drug and got pregnant on it, and also for those women who would like, pregnant women who would like to get injectable cabotegravir. So, or maybe in such cases, oral formulations are better as of today. Thank you.
Brilliant.
So three questions, right, at the same time.
Yeah. So in terms of selection for treatment, because you're asking about treatment, right? So in terms of cabotegravir rilpivirine for treatment, in our unit, we will offer the treatment to anybody who is medically eligible. So if you're virally suppressed, according to the license, you don't have hepatitis B, and you've got no resistance to either drug, we offer the drug, and people can choose to take it or not. So we offer the drug. We don't select. We feel that it's inequitable to choose people. We tell people about it, and if they're interested, then we check if they're eligible medically, and we give them the drug. In terms of safety, it's for everybody. There's very few adverse events. Some people get injection site reactions, but they tend to last for between 3 and 7 days, and they're generally mild. And very few people discontinue due to injection site reactions, very, very few. Like in all the studies, it's like less than 1%. And in our clinical practice, we've got like 300 people on cabotegravir rilpivirine, and we've had one discontinuation. And that was actually in the all lead-in. So we don't see a lot of discontinuations. In terms of menopause, it's very compatible with the hormones. So it's fine. And I think the thing is, even people who are on more than 2 other drugs for other conditions, for comorbidities, in my study still selected, they still wanted to be on injectables. So I think the thing is, people living with HIV, there's something about HIV itself. There's something about being on HIV drugs, every day that you have to see and that you have to take, and that reminds you of being living with HIV, or that you worry someone's going to find your tablets. As a result of this, even if people are taking more than 2 drugs for other conditions, they still wanted the injections for HIV. Okay. So in my study, 40% of people were on 2 or more drugs for other things. So that's my thinking on that. In terms of pregnancy, the lenacapavir study as PrEP allowed pregnant people to go into the study. Okay, they didn't stop people from being pregnant. But for the cabotegravir study, they didn't allow pregnancy, but they have done a lot of measuring of safety subsequently, and there now is a study which is sort of a follow-up study allowing people to be on cabotegravir. So there's quite a lot of experience now with cabotegravir as PrEP. We know for rilpivirine, we've had rilpivirine in pregnancy for many years, and there's no concerns. So with cabotegravir, so far there's no safety signal of concern, but the number of people on the register is low. There's not a large number of people, but there's no concern. In the third trimester and postpartum, we do think the drug levels are a bit lower, but there's no correlate of protection. There's no drug level that tells us this is enough. Okay, we haven't seen people breaking through with sort of postpartum HIV transmissions in the neonate. That hasn't happened, but there've been some reports of lower drug levels. So in terms of pregnancy, again, the important thing that I say to the woman is, once the drug is in, we can't take it out. So, for PrEP, we can't take the drug out. So and the drug can last in women, particularly if there's a lot of fat, up to a year. So if you know that, you know that. There's no real concern from what we know, but it's not like a tablet that you can stop taking it. So that's what I would say. I don't know if that answers your questions.
Дякую дуже.
Thank you
Оля,
very
ви
much.
удовлетворены?
Так, дуже дякую.
So you are satisfied, Olga? Yes, yes. Thank you very much. I got it. Really.
Розумію, що у вас на програмі ПрЕП, так? З каботегравіром 15 жінок, так? І є
So now you
жінки,
have 15 women on cabotegravir as PrEP, and some are pregnant, and you don't know what to do with them, whether leave them on cabotegravir, on this long-acting. So that's why you are asking. It's not that you don't know, but we do not have guidelines in our country, no recommendation. So far, as of today, we don't have any women who got pregnant on cabotegravir yet, not yet. But it's a woman and the age is young, so anything that can happen. But we are waiting for official guidelines from WHO, because as of today, we don't have the official guidelines on that for us to be able to safely prescribe or continue using cabotegravir in women. Do you recommend contraception for those who are taking cabotegravir? We discussed that. As of today in our country, so far, we do not prescribe cabotegravir to pregnant. We offer oral, but again, waiting for WHO guidelines and recommendations. Thank you.
А є жінки, які, скажімо, з ключових популяцій, які
And
хотіли
are there women
отримати
from
доступ
key
до
populations who would like to get
каботегравіру
access to
ПрЕП,
cabotegravir
але
as
вони
PrEP,
захищають HIV,
but
і
they are
ПрЕП
not excluding
немає
a possibility to get
гарантії
pregnant? So
рекомендацій в країні, так?
again, there is no
З цими
recommendation
жінками.
in our country. So what do we do
Тобто,
with those women,
нам
right?
було цікаво
Because for us would be interesting to hear what Chloe thinks about that.
I mean,
If,
I think
for
that if
example,
someone's at very high risk, if someone is a young person with very, very high risk, it's a risk-benefit decision. If someone's at very high risk, there's no real concern. HIV is a concern, and if people can't take oral PrEP, it's a balance of risk and it's a discussion with the patient. I would be in discussion with the person. I'd explain that we don't have enormous amounts of safety data, but there's nothing of concern. But the risk of HIV could really be very significant in some people. And, the evidence is growing. There's more and more data. I think the good thing about lenacapavir is that we do have, there's people were actually allowed in the first place. So there's not necessarily more data, but there is data from the beginning. And we are getting increasing amounts of data as in the real world, as more people become pregnant on cabotegravir. So I think the overarching feeling is that there's a lot of drugs where we don't have sufficient information. This is one of them, but there's no negative signal.
Ну, тобто, якщо жінка хоче
so
продовжувати,
in other words, so if a woman wants to continue regardless of pregnancy and doesn't want to switch back to oral PrEP, for example, so maybe we can allow, because it's her right
Yeah.
to do so.
I would continue in that situation. If I really thought she was at risk, I would keep going in conversation with her, in conversation with her. But if she does stop, it's important that she would go onto oral prep so that she, is, in terms to cover the tail. But I think I would support, if that's what she wants to do, I would give the information and come up with a discussion together.
Я пам'ятаю, як ми долутигравіру.
I remember with
страшилися.
dolutegravir, we were afraid of giving dolutegravir to pregnant, but now everything's fine. So we give it and give it to pregnant women for those who have this desire to get pregnant. So no difference, right? Olga, do you think?
Також ми всі пам'ятаємо,
Yes,
як
yes, absolutely. We all remember with dolutegravir how it started. As of today, dolutegravir is prescribed to pregnant women, and tomorrow I will give all the figures, all statistics during my presentation. There are some risks, but we have to counsel women and to get their consent, right? Yes.
Дякую, колеги.
Thank you. Maybe Caroline or Nina, would you like to join in?
Yes, thank you very much. And Chloe, as always, excellent, just to the point. It's just such a great pleasure to listen to you.
Thank you.
I was wondering, because when these injectables, first of all, I can say from my clinic, we have very few people with HIV on injectables. And I think, and this is in a way maybe funny, but I think it's because for some people, they have just got used to this tablet once daily. They see the doctor now once a year, and then they come every 6 months to get some more medicine, new blood tests, talk to the nurse very, very fast. They don't even have an appointment. So they have to compare this once a year consultation for 15 minutes with 6 visits to the clinic for an injection. They have to, nobody takes out the medicine before they are at the clinic because it's still expensive. So it has to get a little bit warm. They have to wait for that. They have to wait after the injection. It takes much more time. So at least for a lot of my patients, that has been the reason why they didn't want to change from an oral daily tablet to this injection. But regarding women in the fertile age living with HIV, we have done the 2B Mom study, and that's a mixed method study of women living with HIV who are pregnant compared to women without HIV who are pregnant, and compared to women with HIV who are not pregnant. That was a bit difficult, but that was to see. They were asked by a questionnaire how they were feeling and whether they were depressed and what was difficult for them. And then a group of them were also interviewed twice, once during the pregnancy and once 6 months after delivery. And it turned out that one of the things that was really difficult for them was when they had given birth. One thing was that they couldn't breastfeed, and that is changing extremely rapidly now. But the other thing was that they very often had a family member living with them when they gave birth, very often from their own home country. It could be their mother, their sister, a friend, a cousin, whoever. And they were so afraid that somebody would discover their HIV medicine. They are a group whom I really think would love to get these injectables, but we haven't offered it until now because they were in a group where it was said even women who were not pregnant but who could become pregnant were not allowed to get this treatment in the beginning. So I think it could be a game changer for them. That's just what I wanted to add on. And then I think it is fantastic with new treatments that you don't have to take that often, both injectable and tablets. I'm just a little bit worried for hepatitis B, and especially maybe on the African continent. But that's a different story. But yeah, thank you.
Дякую, дуже дякую, Ніно, за ваші коментарі.
Thank you, dear Nina, for your comments. Caroline?
Just one word. Thank you, Chloe. Such a wonderful talk and very interesting. Just a word for pregnant women. I think we have to remind ourselves that most of the pregnancies are not planned. And what Chloe said is right. There's no safety concerns until now. But what we have to do is remind ourselves when women get pregnant on cabotegravir or on other new drugs that we report and that we look at those and that we collect data. What Chloe said is very important, that pregnancies are unplanned and they happened, and so we need to be really joining our data and experiences here to say, okay, this drug, instead of switching because we're getting nervous, which is mostly wrong during pregnancy to switch. So maybe just get more and more women data when they are pregnant. So, and what you said, Nina, is very interesting because I never thought about this. So very good study to see that it's an issue about taking drugs and hiding them maybe. Thank you for that input. Very interesting.
Yeah, I agree. It's really interesting. It's a really interesting point. Yeah.
Так, колеги, я як модератор вимушений
All right, dear
слідкувати.
colleagues, being a moderator, I have to keep an eye on time,
Маємо переходити до
and we have to
наступного блоку.
go further to our next part, to our next mini lecture. That's about monitoring of HIV drug resistance and experience of Ukraine. And it's going to be presented by Maria Lulchuk, Doctor of Medical Sciences, Head of Laboratory of Molecular Virology, Medical Microbiology with the Museum of Human Pathogens, Institute of Epidemiology and Infectious Diseases named after Lev Gromashevsky, National Academy of Medical Sciences, Ukraine, Kyiv. Maria, you're most welcome. Dear colleagues, good afternoon. In this presentation, we are going to look at experience of Ukraine in monitoring of HIV drug resistance. And here I declare no conflict of interest. And here on this slide, you can see the 5 major directions in monitoring HIV drug resistance that are implemented in Ukraine. And the first one is monitoring of acquired HIV drug resistance. And this direction was implemented as part of CODREM study, and that was initiated by the Center for Diseases and Control and Prevention, CDC, under PEPFAR project. So CODREM, patient-level cyclic monitoring of resistance to HIV drugs in Ukraine. This is HIV-1 subtype structure. As a result, subtype A is prevailing, A6 subtype, 88.6%. Subtype B is number 2, 9.6%, and some insignificant quantities are presented by circulating recombinant forms as well. With regards to resistant mutations, we can see that the samples that would have at least one main mutation is 50.7%, which is half of samples had this mutation, and those that did not have 49.3%. Situations when there is no resistance mutations, but the viral load in patients does not decrease lower than 1,000 copies, tells us about the fact that patient is just not taking ARVs, and this inadequate adherence or non-adherence is a very relevant issue for Ukraine. With regards to resistance mutations, and if we are talking about specific ones to one drug class, and usually it's non-nucleoside reverse transcriptase inhibitors, frequency is 14.5%. Nevertheless, we know that we have a combined treatment, combined regimen. So the main drug is non-nucleoside inhibitors, but if there is resistance already developed, so that brings and enhances the resistance development to the first part, to NRTIs. And we can see that 1/3 of all samples, each third sample had combination, like a set of mutations to 2 classes of drugs. And here you can see specific mutations mentioned, but because we do not have a lot of time, we are not looking at them in details. IP, I have to mention, inhibitors have the low resistance level, and also the integrase strand transfer inhibitors have low resistance levels, and which is very positive at this point of time for Ukraine. Separately, we looked at patient data getting dolutegravir, and we can see that adherence is inadequate. In this group of patients, it's even higher than overall for CADRA study. So 2/3 of dolutegravir-based patients didn't have virological success because they were not taking ARVs. Second direction is HIV drug resistance before treatment. And these studies were implemented for the first time in 2023 in Ukraine, and the field phase was funded by the Global Fund, and the World Health Organization provided methodological guidance for us. But unfortunately, for samples sequencing, unfortunately, we didn't have money because Global Fund had some limitations, and we are very much grateful to WHO, who talked to the BC Center for Excellence in HIV/AIDS from Vancouver, Canada, because this laboratory tested 238 samples free of charge for us. And the majority of participants were males, and the prevailing subtype HIV-1A6, almost 97% of all samples had this subtype, and we saw high level of resistant mutation prevalence to NRTIs, especially in those patients who already had experience taking ART. And according to WHO recommendation, if the resistance prevalence to a certain class of drugs is higher than 10%, it's recommended to minimize the use of this class of drugs as part of both initiating regimens, starting regimens, and second-line regimens as well. And that was implemented by Ukraine as well. And we decided to switch over to first-line dolutegravir-based regimens. Levels of NRTIs drug mutations were less than 1%, very low. And also, we didn't see major mutations to integrase transfer inhibitors and boosted protease inhibitors as well. We also saw a high level of polymorphism, which is 89%. This is L74I mutation. This mutation is observed very often in a HIV-1A6 subtype patients, common in Ukraine, but considering that this main mutations to integrase inhibitors, there is lack of those, we decided that cabotegravir as PrEP does not pose any threat for Ukraine and can be reliably used both for prophylaxis and treatment as well. So this polymorphism mutation does not lead to developing main mutations. Direction number 3 is early warning indicators of HIV drug resistance, and to collect these data, we used a WHO-developed electronic instrument, and here 7 major indicators are collected. And previously in 2013, when we just started to collect such data and review and analyze the data, we used the paper forms, and we were taking different data from those paper forms. But thanks to PEPFAR CDC project starting 2021, we have initiated to make this process automated. And we are now collecting the necessary data from the information system for socially dangerous diseases. We have access to data for 6 out of 7 indicators, and we cannot get data about with regards to the stockout ARVs because this informational system does not contain this kind of data. And the target is in green color for each region. We can see some are more successful in reaching targets who are less successful. But overall, for Ukraine, I might say that we are treating very well. The average target is 93.9%, but unfortunately, we have a big problem with covering patients to viral load. With regards to viral load testing, the target here is supposed to be more than 70%. We have 58.6, and the possible reasons might be that we are not doing that within the interval that we are supposed to test, like from 9 to 15 months post initiation of ART. And also the war made it worse for this situation, especially for men, because men are afraid to travel, to come for testing, because while they travel, they can be issued a combat summons, a mobilization order. And it's not only the war leads to that. So here you can see some data as of 2020, 2021. So it's not just the war. And we can see that the viral load testing situation and covering patients with that hasn't changed much since that time. Number 4 direction is drug resistance, HIV drug resistance among newly diagnosed HIV-infected children before 18 months of age. And these tests we've started last year, 2024. We've developed a protocol, and the Global Fund has allocated money for the field phase. And we are expecting that this year, 2025, we already doing the field work, the field phase. We will be able to cover as much babies as possible, those born to HIV-positive mothers, and having 2 positive PCR results to test for proviral DNA. And the last 5 direction is clinical examination of patients with virological failure. And with regards to this direction, we are testing patients for whom we need to think whether we need to switch to a different regimen. So clinical examination is the main purpose of this testing. Annually, about 600 patients with virological failure of ART examined. Annually, the only laboratory having necessary equipment doing this type of testing is the reference laboratory for the diagnosis of HIV/AIDS, viral and especially dangerous infections of the Public Center for Public Health as part of Ministry of Health. So before war, we were procuring tests, reagents, supplies from the state budget, but since the war has started, so the financial support is provided by Global Fund. We are buying Thermo Fisher systems. We do sequencing using Sanger sequencing, genetic analyzer, ABI, PRISM 3500XL is used, but we are looking into NGS platform for future, and the interpretation is and subtyping is done with help of Stanford HIV database. Besides, we've already initiated, thanks to financial support from CDC, PEPFAR CDC, we are procuring external quality control, the QCMD panels. We've started that in 2021. We've already had 4 steps of external quality assessment, and you can see the certificate as of 2024 shown here that we were quite successful in quality assessment. Thank you for your attention.
Thank you, Maria, for this very, very interesting and excellent talk. I am truly impressed with what you have been able to do. That's really impressive. I was just wondering, the patients that you sent for clinical examination, how did you find them? How did you identify these patients? Was that simply because their viral load was not completely suppressed?
Пані Ніно, дуже дякую за запитання.
Nina, thank you very much for this question. Our patients undergo viral load testing at our center, and 5% have virological failure. We understand that 5% out of 100,000 and more people on treatment is going to be much more than 600 patients. It'll make much more than 600. So we prepared a note, developed a note for all physicians who they should send for resistance testing. First of all, doctors have to be sure that a person is taking ARV drugs, so the viral load level shouldn't be 1 billion copies, shouldn't be high, where it's clear that the wild type virus is prevalent. It's recommended to work with adherence in such patients, but for the patients, for other patients who are showing more or less adequate levels of adherence, and in whom viral load level is not very high, up to 10,000 copies, RNA copies, and also depending on what kind of regimen they are taking, if it's a dolutegravir-based regimens, we do recommend to undergo resistance testing. Because if a person is on protease inhibitors boosted and it's 1,000 copies, so it's clear that a patient is just not taking ARV drugs. And we have quotas, so to say, calculated for different regions of Ukraine, percentages where the majority of patients, where the prevalence of virological failure is higher. So the quota are different compared to regions where situation is stable. I also might say that if a viral load is detectable, so you never say no, right? If a doctor refers a specimen to you, so you never say no, right? So if a viral load is detectable and our test kit, that means 1,000 copies and more. So the threshold 1,000 copies. So we can send blood samples for resistance testing.
Дуже дякую, Марія Ігнатівна.
Yes, thank you. Thank you very much. Thank you, Maria. Thank you, Nina. Caroline, do you have any comments or questions to Maria? Because we have a couple of questions in our chat.
Please do go to the questions. Thank you, Maria. Very nice work and brilliant talk. Thank you so much. And go to the questions from the participants, please.
Добре, добре.
All right.
Тоді запитання до пані Марії.
In this case, there is a question to Ms. Maria. Is there geographical differences in subtypes of HIV in different regions of Ukraine, or whether A6 subtype is prevailing everywhere? Thank you for these questions, dear colleagues. So just as the slide shows, though, the majority, 88.6%, is A6 subtype. Number 2 is subtype B. It's more prevalent in Mykolaiv Oblast, Mykolaiv region. How come it happened? So because historically, the epidemic started, it's two epidemics started at the same time. So subtype A in Odessa region in the injecting drug user community, and B type was brought to injecting drug user community in Mykolaiv city at approximately the same time, back in 1994. And those epidemics started to develop. But in Mykolaiv for many years has been a kind of a closed city with limited access to the city. So the subtype B was kind of localized within the borderlines of this region. But A6 subtype has been spread all over Ukraine, outside Ukraine. Right now, Mykolaiv is no longer a closed city, so people can access it, can go in, can get it out, but still we see that subtype B is prevailing there just like before. This is a subtype B. It's not from MSM community, but it's more related to the community of injecting drug users. It is starting to spread in Ukraine. We see some cases and the increase of the proportion of the subtype B in other regions again, but still more localized in Mykolaiv region. Thank you. Thank you. Thank you, Ms. Maria. Thank you very much. All right, so we will see whether we have more questions. Just a minute. For example, Ms. Maria, please tell us how often do you do surveillance on of acquired HIV resistance? So the usual resistance and vertically transmitted resistance. Thank you for this question. So we developed the procedure for surveillance, resistance surveillance, and we believe that each of those approaches have to be monitored every 3 years. With regards to acquired resistance, no need to do it annually, no need to do it every year. To overload laboratories, to overload the budget in our country. There's going to be a switch over to state funding. So we are going to go from other funds to state funding. So we believe it's better to do it every 3 years. So back in 2023, it was monitoring resistance before treatment. And next one we are planning to do in 2027. In 24, there was monitoring of acquired HIV resistance. And in 3 years, we are going to do the next round. And thus, every year, we are going to do maybe 600 to 1,000 testing to analyze, to conclude whether there is any problems with each of those directions of work, and to do some corrections if there are some problems. Thank you. Thank you very much. All right, dear colleagues. Again, going back to our agenda, we also plan to look at some clinical cases, also going to be presented by Ms. Maria. So I think maybe we will do that. We will hear about the clinical cases and then the final discussion after that. If you don't mind, all right, Maria, you're welcome. Dear colleagues, within the framework of this presentation, we will review some clinical cases of acquired HIV resistance in women. The first case is about a patient born in 1973. She was diagnosed with HIV in 2014. She has higher education, higher school. She is not married, the route of infection parenteral, injecting drug user. The starting CD4 lymphocyte level in 2014 was 30 cells per microliter, or 10%. And after that, at the time of resistance testing in 2020, the CD4 count was 89 cells per microliter, which is 9%. At the time of testing, she had a positive HCV status and residual signs of tuberculosis. ART history. The patient had 4 previous ART schemes in her history. She started on TDF-3TC plus efavirenz, and she was on that regimen for 1 year, since December 2014 till December 2015. Then she stopped this therapy, and as long as she had signs of TB, it's quite possible that she was getting treatment for tuberculosis at that period of time. Then therapy was reinitiated in July 2016, AZT3TC efavirenz, and she is taking that regimen for 3 years. And she was tested, her viral load was tested, and she never achieved suppression, so virological effectiveness was not there. But still, the regimen was not changed, and Phil was on AZT efavirenz for 3 years. Then in August 2019, they switched to TDF-FTC dolutegravir. She is taking that regimen for 1 year and 4 months. Her viral load level is 3,615 copies, and then she switched to TLD. That was in August 2020. And on this current regimen with viral load level 22,659 RNA copies, the patient is tested for whether she has a resistance. So results: protease inhibitors, no major mutations, susceptibility is there. Integrase, strand transfer inhibitors, INSTI, 3 major mutations, very potent ones, and 2 additional mutations. And at the end, there was a cross-resistance to the entire class of integrase strand transfer inhibitors. Then nucleoside reverse transcriptase inhibitors have a look at set of mutations developed under AZT. This prolonged, inefficient, virologically inefficient regimen use led to RAT complex. So 4 out of 6 possible mutations. This is cross-resistance to the entire class of nucleoside reverse transcriptase inhibitors. With regards to efavirenz and nevirapine, also a set of mutations are seen here. And finally, both of those drugs stopped to be effective. So this is the overall situation. So when nucleoside inhibitors and cross-resistance non-nucleoside inhibitors, also we see cross-resistance. INSTI, the integrase strand transfer inhibitors, also cross-resistance is here. And finally, there is only one class is left, which is boosted protease inhibitors. Still, there is some susceptibility maintained. Clinical case 2, less dramatic, but also interesting. The patient was born in 1979, was diagnosed with HIV in 2015. So she has a high education, not married, route of infection sexual. CD4 cell count in 2018 was 87 cells per microliter, 20% in 21, it became 175 cells, but the percentage decreased. Not infected with hepatitis C virus, and she also completed a full course of TB treatment. So now we have a look at ART history. 2 regimens in her history. First, TDF FTC plus efavirenz. She was on that regimen from October 2017 to February 21, and then switched in February 21 to abacavir, 3TC plus dolutegravir. Again, I emphasize and point your attention. So have a look how viral load was tested. So 4 times in 2019 and 6 times she was tested in 2020. So viral load was tested that many times. They saw that the patient she did not achieve virological success, but the regimen was not changed. So that regimen was failing during 4 years. So now we are looking at HIV-resistant test results, protease inhibitors, no mutations, and susceptibility is maintained. Integrase strand transfer inhibitors, 2 quite powerful mutations there, major mutations were found, and the level of resistance to cabotegravir was high, and the average with regards to dolutegravir and bictegravir. So there is a question, how come a patient on this regimen, which is dolutegravir-based regimen, has been only for 1 month at the time of testing, but still we have such outcomes, such results. How come it happened so? That's only because the first part of the regimen stopped working. So there is resistant mutations to NRTIs, are there to abacavir, high-level resistance, and tenofovir, also high-level resistance as well. Still some susceptibility maintained only to AZT. Speaking about non-nucleoside reverse transcript inhibitors, efavirenz, high level of resistance, nevirapine, also high level of resistance. And finally, the patient has the following situation: susceptibility maintained only to AZT, full susceptibility only to PI protease inhibitors, and medium level resistance to dolutegravir and bictegravir. So I would like to conclude here with regards to these 2 cases. First, that the patient adherence level to treatment regimen still remains to be a problem in Ukraine. Number 2, physicians, doctors, on their part, also contribute to the development of resistance, because for 3, 4 years, even 2 years, but they keep a patient on a regimen when there is no virological success. It's virological failure. It's always a danger of HIV drug resistance development. Next thing, it's crucially necessary to have access to new innovative HIV drugs. And the last thing, we cannot and should not minimize the class of boosted protease inhibitors, because in the majority of cases when we see such complex situations, only this class of drugs in many cases allows us to save patient lives. Thank you for your attention.
Thank you so much, Maria. This was amazing that you also prepared such interesting cases. And I think very difficult cases, because we don't know what you said as a conclusion, that it's really difficult. On the one hand, this patient seemed to be kind of adherent, because she came also for the viral loads and you did loads of measuring. And my question is, how do you normally find out if women are able to take the drugs or if they just didn't take it? And the other thing was, do you think that we should be more, see those patients more often and ask them if they have problems, or did you do the viral load in normal checkups, or did she come because she wasn't well. So I didn't get that point because there seem to be have many
Okay.
clinical controls, and maybe you could have switched further. But thank you for those really important cases.
Дякую, Керолайн, за
Thank you, Caroline,
запитання.
for your
Ми
question.
визначаємо
So we
відповідно рівень
test
високого навантаження.
viral
Це
load
єдиний
level.
критерій, золотий
This is
стандарт,
the only
який
criteria,
дійсно
so to say. It's a
не
gold
обмане,
standard
який
that
покаже
not
картину, чи приймає
deceive you,
пацієнт
so to say, and will show the
препарати, чи
real
не
picture
приймає.
whether the
Дійсно,
patient
коли
is taking the drugs or not. It's true. Previously, most patients were on NNRTIs. Previously, yes, on non-NUCs, so to say, and we understood it's dangerous to keep them on inefficient non-NUCs. And empirically, we could switch a non-effective regimen to dolutegravir-based regimens, for example. But now, in these times, when the major proportion of patients is on dolutegravir, and we minimize the use of non-NUCs here, it's difficult to say whether the patient is taking or not taking, because the patient maybe in the past did not take, but now is taking, but there is no virological efficacy, or maybe before the patient didn't take and then mutations developed, resistant mutations developed, and now on dolutegravir, it's very difficult to say without testing, to say whether there are mutations or no. But in any case, our doctors, if they can, when they can, they ask about adherence at each visit. And also they work on developing adherence. And it's very important for women to do that, to develop adherence. It's for women. But what we see, the major, so to say, part who is not adherent is men. There are kind of some behavioral, issues that prevent them from timely taking ARVs. But maybe if during our conference, if we are talking about women, about problems, challenges, treatment, so we are talking about women more. So talking about those two cases, how come we test them that often? So explanation. So the reference lab is getting samples from all over Ukraine. In particular, those samples were from other regions, and we asked doctors, how come you kept those female patients on inefficient regimens for so long? And doctors mentioned that during all that time, we were working on the adherence. So we were trying to develop the adherence to treatment. But every time we do the training, we also explain to doctors that for drugs with a low genetic barrier, just like non-nucleoside reverse transcriptase adherence, it's not worthwhile to keep them on them for a long time. So if it's for the short time, you can see it's non-effective. Don't keep them long, because if you keep them long on those non-effective drugs, you will just develop cross-resistance. And sorry, I forgot, maybe you have more questions. And if it's okay for you, Caroline. No? Also, there was a question, how come you did testing that often? Well, yes, Caroline, they did that often, which didn't help the patient. It didn't help the patient, that frequency. They tried to do something. Well, it's easy to say we are trying to develop adherence, but like easier said than done. Probably it was difficult for them to actually do it. So every time when they tell me, for example, well, we have to ask the patient, I always tell doctors, you have to ask questions to yourselves first. Of course, you have to ask patients as well, but ask yourself, okay, how come? Ask yourself, how come you are keeping patients for on those regimens? non-effective regimens for such a long time. And my question is, dear Maria, for example, with regards to efavirenz 400, so when we received efavirenz 400, did it matter? Because Europe is no longer using efavirenz 400, but just 600. But we are still using efavirenz 400. It's not about those cases that you discussed now. Well, but I would like to say, I think that all our actions, for example, looking at drugs, poor attention towards adherence, everything together led to the fact that we had to minimize that class of drugs within the regimens. So to get them out of the initiation regimens and to make them second line regimens, drugs within the second line regimens, because, you know, it has some impact. So all factors together led to that.
Дякую.
Thank you. Thank you. Right, unfortunately.
Дякую, пані Марія. Колеги,
Thank you,
хочу
Ms. Maria.
підкреслити,
Dear colleagues, I
вас
would like to
рівень
mention
залученості
that
подає
more than
інформаційних
110 participants are watching us.
зараз через вже
Even now,
півтори
it's
години після
1.5
початку
hours
засідання.
after the
От
start.
якщо
Yes, they're
13
still watching us and asking
тому
questions. 114 at this point of time. So it's
колеги, у нас є
wonderful.
ще одне, до речі,
All
запитання
right,
в
dear
чаті.
colleagues, we
Хотів
have
би
another
перевірити,
question from
чи
the chat, if you
мають
don't
вплив такі
mind.
фактори, як
So,
стать, вік, супутні
gender,
захворювання
age, and
пацієнта,
comorbidities,
наше
such
особисте
factors,
бажання
do
бути
they
резистентним
impact
до antibiotics.
the
Було б цікаво
acquired
почути
HIV
відповідь
resistance
може бути
development?
Україні,
So would be nice to hear about that data in Ukraine, in Denmark, or Switzerland. Maybe just quickly, I'll mention about Ukraine. We did the multifactorial analysis, neither gender, well, maybe gender has an impact, but the majority are men because they have some biobehavioral peculiarities. But the multifactorial analysis where different factors joined together, and we were looking whether all of them have an impact. So we found out that TB and duration of treatment more than 24 months are the factors for developing resistance.
Зрозуміло.
Okay, thank you.
Може, є
Nina, maybe
Yes,
you
may
have
I
some
just-
comments?
May I just ask you, because I noticed that I think both the women you mentioned were hepatitis C co-infected with the HIV infection. So my question is, do you treat the hepatitis C virus infection up front when you diagnose it, or do you have any barriers to treatment for hepatitis C?
Я, наверное, попрошу пані
Probably
Світлану
I
Антоняк.
would like Ms. Svetlana to comment on that, because my direction of work is just is resistance, anything related to resistance. But I have nothing to do with treating hepatitis C, so I would like Svetlana to comment. Thank you. Thank you, Maria. Yes, I would like to say yes, we treat hepatitis C as of today, yeah. But sometimes there are some periods that we don't. For example, direct action drugs. We started to have maybe back in 2018. So first we treated with interferons, and I have experience treating with interferons, treating patients with HIV, about 1.5, 2 years. It's a very difficult pathway, but patients did it. They had to be treated like that. And after that, we started to have the direct action drugs. And our hepatologists liked still interferon treatment. So I don't know, but it was my idea. I personally wanted to combine. So we received only sofosbuvir. And my idea was to combine interferon and sofosbuvir and treat 12 weeks. And ribavirin when it was needed. But 12 weeks is not a year, not a year and a half. It's not 48 weeks, but still it's just 12. Not 48, not 72 weeks, but 12 weeks. So thus, in the beginning, it was interferon plus sofosbuvir that we started to use. Now we are Sofwell. We are using Sofwell direct action, Sofdoc for some period, but WHO tried to sell it to us as pan-genotypic, but it's okay. But it's good so that we have at least Sofdoc. And now we have Softwell. So that's how we treat. Sometimes it happens that we might have some barriers from time to time, like with supplies, stock out, maybe a little bit. But most of the time, our patients have access to treating Hep C. And it's been for quite a while that they have this access. So this is the situation in that. Yes, yes.
That sounds really good. Do you see reinfections after DAA treatment?
Знаєте, бачимо, але
We do see, but very rarely, very rarely. Well, of course, we would like it to be even more rare, but we were afraid it would be more frequent. It's not as frequent because we were thinking if it's an injecting drug users that they can get reinfected. But in fact, we don't see that many reinfections. But that's my personal opinion. That's what I see. But we do have such patients, but again, rarely. And in order to say whether it's a reinfection or not reinfection, we have to do genotyping. In our clinic, we do genotyping, so we are able to say whether it's reinfection, where it's just infection, or relapse. But that happens rarely.
Thank you. That's very interesting to hear. Thank you very much.
Дитина має пацієнта коінфекцію вірусного гепатиту С, але ефект дуже добрий від лікування.
So we have very good effect of treatment.
Часто інфікуються і реінфікуються.
So no frequent reinfection, no.
Вспомнила про свій опит лічення гепатитів.
Yeah, I just remembered my experience in treating hepatitis. So, would you like to say something or to ask something? Nina, Caroline, Maria, Sergey, we still have 5 minutes till the end. I would like to ask Chloe, as long as we have multi-resistant forms and we see that in women, would like to ask what's the potential or what's the efficacy that the new drugs carry, that the new drugs have, the integrase strand transfer inhibitors, third generation, and BNAbs, whether they are successful and working well in patients with multi-drug resistance, including multi-resistance to INSTI, because majority of patients, of our patients, are on dolutegravir-based regimens. So for us, it would be very useful and beneficial to have access, of course, to such novel drugs. But the question is whether they're effective to fight the multi-resistance. Thank you. Dear Miss Maria, unfortunately for technical problems, Chloe had to leave. So maybe Miss Nina or yes, maybe Caroline, Nina and Caroline. So what do we have? There are some patients that we have, not too many, but in whom we have only one active class of drugs. Protease inhibitors are just working for them. Of course, it's a powerful class. We don't use them and have not been using them too often, so we still have it active. So we are forced, we have to provide patients only one fully active drug, but others, all the rest, are just partially active. So that's the story that we have.
Як ви хочете доступу до новітніх препаратів, Caroline і
And how about access to novel drugs? Nina and Caroline, what's the perspectives from your point of view? Of course, we cannot ask Chloe because she is not with us now. Do you have access to injectables in your patients? Nina has mentioned that not everyone would like to switch to that.
But the ones that I mentioned, that was patients who do not have resistance problems. So I think that's another group. But I think there are, even though it's not my specialty or my focus area, I know that there are new drugs coming up, and we have had a very few patients with severe resistance problems. And in Denmark, we have to apply on an individual level for these patients to get the new medicine. But actually, it has turned out that there are possibilities, even for patients who are multi-resistant. But of course, it's not everybody who can get access to them, and we have to apply, but it is possible, definitely. I don't know, Caroline, do you have anything to add?
I think Nina is more expert in this kind of because I would call my colleagues to give advice, because I just know what I notice from my patients in IC women is that not many of them are on injectables, what we discussed today a lot. And I was wondering why that is. So I think the study of Chloe is very, very meaningful to find out what is the concerns and what patients think about that. And I found also the aspect, Nina, you told us that they need more appointments. Even if it seems easier, they need to see the doctor more often, which makes them more aware, I need something, I have to go in the waiting room. And I think that is a point. And in Switzerland, as I said, not many on injectables, but we have, of course, the resistance issues, but dealing by infectious disease colleagues from mine, and getting new drugs is very important, and experience for women. And I'm, of course, then when they get pregnant, or that's the problem with the newer drugs that we need, that we don't know a lot, and it takes a long time.
Дякую.
Дякую, шановні колеги. Ну що,
Thank
ми
you,
вже
dear
фактично
colleagues.
вичерпали наш
So,
порядок
okay,
денний.
so
Можливо,
we
ще
are done because our time is up. Of course, as always, we would like to continue, but I believe that maybe final words, and then we will say goodbye. The only thing to remind that tomorrow is our second day of the 13th practical webinar on track to health of women. And tomorrow we are going to talk about reproductive health most of the time. So please join in. You will like it, hopefully. So maybe just final words. Who would like to start? So maybe I will be the first. Thank you very much, dear colleagues. Thank you, Professor Nina Weiss, Caroline, our favorite Caroline, for being with us. Of course, your experience, your knowledge to communicate is really useful to us. Of course, you live in a country with more resources, so we are very much grateful to you for your help. You are helping us, and thus you letting us know more about your experience of your countries, and it helps us in our lives. Thank you. Dear Maria, thank you very much to you as well. I agree with Nina that, of course, when there is resistance to multiple classes of drugs and there is only one class available, so it's difficult. of course, in this situation, it would be nice to have access to more drugs, and it's our dream. It's our dream, but of course, it's up to doctors and the healthcare system as well to develop that resistance. But nevertheless, thank you very much. Hopefully tomorrow is going to be another interesting day. So for us, it's always like it's a
Можна я
festive
теж
day.
скажу пару
I
слів
also would like to
по-українськи?
say just a
Спочатку
couple of
подякувати
words.
і
I would like to
організаторам за
say both
честь
the organizers for
представляти
this
дані
honor to
України.
be able
І
to
хочу
present
дуже
Ukrainian
подякувати
data.
нашим
Also, I would like
колегам,
to
пані
thank our
Ніні,
colleagues,
пані
Ms.
Caroline.
Nina, Ms.
Ми
Caroline.
кожного
Every
разу
time
доєднуємося до
we
цієї
join
зустрічі.
such
Дякую
webinars with
пані
joy,
Світлані, пану
happiness.
Сергію
Thank you,
за
Svetlana.
організацію.
Thank you,
Це
Serhiy, for
який
this
13-й
organization.
раз
This is the
поспіль, і
13th
кожного
time.
разу ці цікаві
But
теми,
every time
кожного разу ця
topics are really interesting.
інформація,
Every
вона
time there is new
тільки
information,
свіжайша,
so to say, the
тобто
newest, the
отримана
most
з
fresh,
конференцій
just
наукових,
received
і
from
бачимо, що наука не
scientific
стоїть на місці, йде
conferences,
вперед,
gatherings,
і
on
наші
congresses,
колеги
researchers
цифрами
ongoing, and the
доносять,
colleagues are giving
розповідають
that
про те, що
information
все це
to us
приносить
all the
користь
time
для
because
лікування
we
жінок.
want
Ми вам
to
дуже вдячні.
care
І
better
дуже
for our women,
сподіваємось,
for
що
all
і в
people with
наступному ми
HIV, and
теж
hopefully
будемо
that
мати таке
in
задоволення
future we
і
will have this
приймати
privilege
участь і
and
слухати
happiness to
інформацію
continue to
з
hear
вас,
more
прекрасних
information
гостей.
during
Дуже
our
дякую.
next meetings and webinars as well. So thank you.
Дякую, дякую, пані Марія.
Thank you, Ms. Maria.
Ольга,
All right,
просимо пару
Olha,
кілька слів для наших
maybe
глядачів.
just a couple of words.
Ольгу ми завтра будемо мучити.
Добре.
We will torture Olga
Я
tomorrow more.
приєднуюсь до привітань.
Yes,
Бо
but
подивилася,
I
наскільки
also would like to
красиво,
thank
все
everyone.
корисно,
Everything was
взагалі
useful,
прийшло все
very,
новітнє.
very useful for our
Тому
country. A lot of new
дякую за
information.
можливість
So thank you for this
присутствувати
opportunity
на цій
to
вебінарі.
participate and get this new information.
Дякую, дякую, Ольга.
Thank you, Olga. Nina?
Клас.
I thought I was going to be the very last after Caroline. But anyway, I would like to say thank you very much on behalf of WAVE, Women Against Viruses in Europe. I would like to really thank especially the organizers, Sergey and Caroline, so much for this interesting webinar, and also to all the speakers, Chloe and Olga and Olna and Maria. Thank you so much for your presentations. And I wish you a fantastic day tomorrow. I'm sorry I can't participate. And then I already look forward to next year's webinar, the 14th. So thank you very much for having me.
Дякую, Ніна.
Thank
Ну,
you.
Caroline,
Thank
що,
you.
декілька
Thank you,
слів?
Nina.
Yes.
So Caroline, please, you're
Thank
most
you.
welcome.
Yeah, I also want to thank all the speakers, first of all, especially Maria and Olna for preparing their talks. And I would like to thank especially Sergey and Svetlana, because without them, we couldn't keep it up, because Sergey is always reminding us and planning the program. That's so important. And I thank also Nina for being a brilliant co-chair. And I think this webinar shows that we keep it up to have this strong collaboration. And it's not like Svetlana said that we help you. I think it's vice versa. You help us to remind ourselves what is really important in HIV care, humanity, and supporting each other and exchanging knowledge. So this is what you help us too. It's not a one way. And I thank also the technical support and especially all the participants who took time to sit in 1 hour and 50 with us. We're a bit 2 minutes late, but that is okay. And thank you. Looking forward to the next goes.
Дякую, так. Ніно, і якщо я не помиляюся, наш
Thank you,
наступний
Nina. If
14-й
I'm not mistaken, our 14th webinar is May next year. And at that time, you are going to be chair, WAVE chair. Hopefully, you will join us as well.
Будемо завтра без вас, Ніна, скучать.
And we'll be missing you tomorrow, dear Nina. And
Oh,
thank you
thank
very
you.
much.
And I hope you will all be members of Wave. If you are not already members, then that's a possibility. So please sign up and sign in for Wave. Have a very nice evening to everybody. Thank you so much.
Побачимо завтра, колеги.
Спасибо за
Bye-bye.
дружбу. Вы даете нам
See you
надежду.
tomorrow. See you tomorrow. Thank you for your
Bye-bye.
friendship. Goodbye.